Delighted to introduce Annie Clothier. Annie is a clinical nurse specialist at Aneurin Bevan University Health Board, NHS Wales in Gwent, and also a member of the Legs Matter Coalition. And Annie is going to speak to us about the use of compression in combined arterial and venous insufficiency. So I'll hand over to you, Annie. Thanks ever so much.
Thanks very much to Society of Tissue Viability for asking me to come and present. So yes, I am a vascular nurse specialist. In a previous life, I was a tissue viability nurse, but I've gone over to the dark side of vascular because I really enjoyed looking after legs. So today I've been asked to speak about compression in mixed arterial venous leg ulceration. And hopefully it'll work now. Next slide. There we go. So leg ulceration falls under a few categories. Most of us know that it can either be venous, arterial, or of a mixed etiology. And the cost of leg ulceration, as we all know from guests' work, is a major economic burden for the NHS. And when we break down the different percentages of leg ulcers, we can see that between 70 to 80% of leg ulcers are venous, 10 to 20% are of a mixed venous arterial nature, 10% of those are arterial, and a small number are related to other causes, could be factitious ulceration or due to rheumatoid arthritis, all sorts of things like that. So there's quite a small percentage that are actual arterial ulceration. And what you may often find is that most of these patients will present with predominantly a venous presentation. So when we talk about what is mixed arterial ulceration, so it's a coexisting disease process, and unfortunately, because today we don't have the time to explore the differences strategically between arterial and venous insufficiency, but I think we all recognise in our patients those classic signs of venous ulceration and also those ones that we know are predominantly arterial as well. But occasionally our patients do throw us a curveball. So this mixed arterial venous ulceration is described as this coexisting disease process. So you've got factors of venous insufficiency and arterial insufficiency. And UMA produced a document back in 2023, which discusses that 15 to 20% of our patients with venous leg ulceration will have coexisting peripheral arterial disease. And that's defined as an ABPPI of below 0.8. So diagnosis then. What is mixed arterial ulceration? It's the presence of this venous and arterial insufficiency resulting in ulceration from one or both pathologies. 90% though of your diagnosis in these patients will come from a good clinical assessment. And I think that this type of insufficiency is basically what it says on the tin. But its clinical significance out there in the real world and its pathophysiology isn't always that well understood, I don't think, amongst clinicians. What is imperative, though, in diagnosing these patients is that you have this good clinical history. So talking to them, have they had any previous vascular involvement? Are they known to us as a team? Have you noticed when you're looking through their notes, have they had any previous surgery on their lower limb? Could they have had venous intervention or any arterial revascularization? Also, when you're talking to your patients, do they have any history of cardiovascular disease? They will undoubtedly have possibly have had an MI in the past, but they will absolutely have things like hypertension, possibly have had a history of smoking as well. But then when you look at their leg, they will have this classic venous presentation. So you'll have, as you can see on the pictures there, hemosiderin deposits, ankle flare, the typical presentation of ulceration in the gaiter region. And there may also be evidence of varicose veins as well. But when you're doing your assessments, things like ABPI and TBPI, if you've got access to that, will guide you. But it's important to also think that you haven't just got to focus on the numbers. And this is something that I say time and again when I'm teaching. Yes, they are a really good test to guide you. But for me, it's about the clinical assessment of that patient. What sort of risk factors have they got? Is there anything within their medication history that gives you a clue to those if they forget to tell you about what other problems they have in their medical history? So it's important that these tests are the icing on the cake, and they could well confirm your diagnosis, and they're there to help guide you in your decision-making process. I think with this ulceration, it's mixed, but it also causes a lot of confusion as well. And these patients do present a problem, because I think as soon as you think about arterial disease, people get very, very fearful about applying compression in this cohort of patients. And this is where I think that certainly MDT and that multi-level approach to caring for these people is crucial. And that's the only way that you're going to achieve necessarily a good outcome for them. It's important for people out there in the community to think that if you are concerned and think, I don't really know what I'm doing with this patient, I'm a bit cautious about applying that compression, refer them on. Make a point of going out to speak to your vascular team, vascular nurse. We're quite a friendly bunch, and we'd be quite happy for you to come and contact us, have a discussion. I know I certainly am in my area. People can email me and we can have a discussion about patients and see whether or not they need to come into clinic. Is there another way that we perhaps need to manage them so that we're supporting you guys in the community and feeling more confident in treating these patients? It also then gives you access to using more correct diagnostic imaging. So I'm very lucky that if I have patients referred to me in clinic, I can book a duplex scan. I can ask for an arterial and a venous duplex scan, and then that will guide me then to know whether or not which is the most pressing part of this disease process that I need to treat first. Do I need to look at the arterial disease, or is that actually quite stable and I can go on and treat the venous disease? And as I've said on the bottom there, it is really important that we support you as community colleagues and that we work together for the best outcomes, because we're sharing a lot of these patients. So we should all be singing from the same hymn sheet and doing the same things. So treatment options. And like I said, there's a lot of confusion about should we compress. From my point of view and from the literature, it says that we need to optimize the underlying venous and arterial disease. So treatment for venous disease, you would be referring them on to the vascular department for us to consider whether or not this patient is suitable for endovenous ablation. So endovenous ablation is where we will insert a small wire up inside the incompetent vein, and then we will activate the wire so that heat is expressed inside the wire, and it will burn, as I say to some of my patients, I'll burn the vein from the inside. And that helps to block off that incompetent vein that is allowing that backflow through that vessel and causing venous hypertension and varicose veins and ultimately ulceration and that skin damage as well. So that will help to get rid of that side of the problem. And I think there's still a lot of confusion out there in the community that some patients don't necessarily get referred with venous ulceration to us because there's a concern that we won't treat them, but we will. And we know this from studies such as EVRA, that this is gold standard treatment for these patients. And certainly this is something that we are trying to push with Legs Matter, as it's Legs Matter Week, that if you are worried or you have been treating these patients for a long period of time, think, should I refer them? Should I send them on for a little bit more of an assessment? Are they suitable for venous ablation? And we can certainly have those discussions and investigate those patients more. The other part of the disease is whether or not they need optimization of the arterial disease. So then we would look to, again, scan these patients and see where the arterial insufficiency is. So that would be lack of blood getting down the leg as opposed to lack of blood getting back up the leg. Angioplasty and anything that we do in vascular carries an awful lot of risk and is certainly not something that we entertain lightly. And it's not just popping a wire in at the groin and passing it down through the artery. There are a lot of risks involved with that. And obviously we need to have very deep discussions with patients around consenting them for treatment for this. But if we are able to perform it and we do pass a wire down through the groin, down through the affected artery, and we're able to stretch open any narrowings, then we will. And sometimes we need to pop a little stent in as well to keep that vessel open, to allow that flow of blood to pass down through that limb. And obviously the main thing that we're looking at is that treatment should be adapted to the severity of the two diseases. So we're looking to see which is the most pressing issue here. Is it because there's not enough blood getting down there, or is it because we need to ensure that we're getting the blood back up properly? I really like this document, and I don't know if any of you've seen it, but this is the UMA document from 2023. And there's a nice little part in there that talks about venous leg ulcers with coexisting PAD. And it talks about 15 to 20% of patients, as we've said, with venous leg ulcers have this coexisting peripheral arterial disease. And it shows as well that how important it is identifying the etiology behind that ulcer, how it started, and how that basic assessment of arterial status is important. So trying to get that ABPI as soon as you can. There are some patients, unfortunately, that can't tolerate an ABPI. So then there's always the possibility of doing a TBPI. It talks about as well how important compression therapy is, and that it's a keystone in treating these chronic ulcers. And we need to try and dispel this myth that these patients aren't always suitable for compression. If you've got a very swollen limb and you're satisfied that the ABPI is of a reasonable level, or if they've already been reviewed by Vascular and perhaps we've said that we can compress, then that is certainly something that you should be continuing with, because that leg is only going to deteriorate without that reduced level of compression on it then, to try and get rid of that edema and stop that limb from deteriorating. I do urge you to go away and have a look at this document. It is very interesting and certainly will help guide your practice. There's lots of other discussions in there about managing different types of lower limb diagnoses. So please do go and check it out. So a lot of the discussion I get, particularly from community colleagues, is whether or not we compress. And an important thing is that arterial disease is not a contraindication as such to compression. The contraindication is the critical ischemia. Now, those patients with critical ischemia will not let you near their legs with any type of compression, and certainly trying to ABPI them can be exceptionally painful. And I'm sure you've all seen those patients with critical limb-threatening ischemia. They find it difficult to keep their legs in bed at night. They complain of rest pain, which is unrelenting pain in their lower leg. They can't get any respite from it. And I think this is where the UMA document is very important, that it helps you to identify the etiology behind the ulcer and how important that is. And talking about the basic assessment of that arterial status, how it should be performed to help to quantify the degree of the arterial component. And remembering that ABPI is there to guide you and inform you whether or not there is the presence of arterial disease. It doesn't tell you about the presence of venous disease. So when you get your ABPI results, we're looking of an ABPI between 0.6 and 0.8, thinking about modified compression, and certainly applying that under close clinical supervision is really important. And there's no reason why you shouldn't be compressing in patients with that ABPI level. It's important, though, to make sure that these patients are assessed and that we're talking about whether or not they're able to cope with that level of compression as well. And as we all know, that compression is not a one-size-fits-all. And having that discussions with them about trying different types of bandage systems or different types of hosiery garments is all very important in reaching consensus with these patients, so that they feel comfortable and that they can comply with the treatment. And hopefully we can try and get somewhere with them with healing their ulceration. The UMA document does talk about exceptional attention is needed among those patients that suffer with neuropathy. And that's particularly important because these patients can't tell you if they feel that their ulceration is more painful than normal, because they simply don't have the peripheral nerve supply to tell you that, because they can't feel it. So it's important to keep an eye on these patients to avoid any skin damage that could follow along with the use of compression therapy in this cohort of patients. So I had a little look around for lots of different evidence as well, and there's quite a bit written about managing mixed etiology ulceration. And certainly one of my favourite documents is from a gentleman called Mosty. And this document dates back to 2012. Very interesting document, but it just surprised me that even though these things were being discussed back in 2012, have we come forward anymore? But I think that fear of still applying the compression in this cohort of patients is still there. And thinking about how we can change that, particularly as we're in Legs Matter Week now, having those conversations and maybe making a point of going to visit your vascular team and having a chat if you've got patients that are in this cohort, and seeing how you can make things better for them, and also helping yourselves, because it must be huge on your caseload. So Mosty talks about, and I've highlighted some of the ones that I felt were particularly pertinent, in patients with mixed arterial venous ulceration in the lower extremities, looking at that ABPI, if it's greater than 0.5, and you've got an absolute ankle pressure of greater than 60, and this absolute ankle pressure is something that we look at particularly in vascular. We're always looking for the absolute pressure. Then inelastic compression systems of up to 40 doesn't impede arterial perfusion, and that's quite interesting. And when I teach ABPIs, I will put the compression cuff on people's arms, and the clinicians are always quite surprised to feel what 20 millimoles of mercury feels like, and how it's really quite not that constricting, and then pumping it up to 40 and just feeling what that is like as well. And we're aiming for a snug compression system, and that's what I tell my patients, that it should feel snug. But it's interesting to see that level of compression does not necessarily impede arterial perfusion in those patients with that ABPI of just over 0.5 and an ankle pressure of 60. And it talks about supervised modified compression therapy that's been shown to achieve 68 and 53% ulcer healing rates in patients with moderate and severe arterial disease. And I'm in clinic at the moment, and this is certainly something that we've experienced here. We had a lady that is not suitable for any arterial revascularization. She has mixed disease, and I would say that her arterial disease is also quite severe, but we trialed her in a modified compression system, but it just wasn't enough. This lady had the typical inverted champagne bottle legs, and we just needed that extra bit of squeeze, really. So we took a punt on it, and we did increase her up to the 40 at the ankle. And it's been a life changer for her. Her leg healed within, let's say, 3 months. She'd had that ulcer previously for about 6 months before. It had gone right down to the tendon, but we were quite strict in how we approached it. She was seen here in clinic on a weekly basis, and we redid the bandaging, and every time you could see that there was improvement and improvement. So that just goes to show what Mosty is saying, but I think we need to think about how we change our practice as well. Further down then it says about localized edema is relieved since the local hydrostatic pressure is increased and the superficial venous pressure is decreased, and this in turn reduces the leakage of fluid. And this is certainly what we could see with this lady I was just talking about, the change in the shape of her limb, and just how that leg dried up, and we were able to dry up that ulceration and encourage healing. And she's in full length compression hosiery now at class 2. And Mosty also talks about compression therapy leading to an increase in that transcutaneous oxygen pressure, and also then secondary to increased cutaneous blood flow. So helping to get that oxygen down to the wound bed, and then also helping with that blood flow right at the capillary bed as well. He also talks about initial treatment phases of this mixed arteriovenous ulceration. Reducing lower extremity edema is critical. So thinking about using inelastic bandages or elastic or multi-layer bandage systems, they can be applied in combination with whatever wound care you're using. And I don't like to talk specifically about different types of dressings. For me, it is sorting out the underlying problem. And I always say that you can put whatever dressing you need to put on there to get the right environment, but that is never going to get better unless you treat the underlying cause. And we've talked about identifying whether or not it's an arterial cause or whether it's the venous, and addressing which one is the most pertinent at the time, and then coming back then to the other cause and sorting that out. And things are not going to improve until we have looked at that. So I urge you to go and have a look for Mosty's work, and if anybody wants the references, then I'd be happy to share that. So I just wanted to talk about little case studies. So this was another lady that we've been looking after. So she was an 86-year-old lady, and she'd had a 2-year history of non-healing ulceration. She was being looked after by the tissue viability team, but they were concerned that there was an arterial component. So we did a venous and arterial duplex scan, which did show that she had superficial venous incompetence, but then there was also a superficial femoral artery stenosis, which was greater than 75%. Now, we don't always intervene with angioplasty unless the stenosis, or the narrowing inside that vessel, is shown to be greater than 75%. So that was causing quite a significant arterial insufficiency for her. So we took her under our care and we performed an angioplasty on that stenosis. So the most pressing part of this lady for her was the arterial component. So we addressed that. Once we knew that we had improved the flow down the leg, then we could look at improving the flow back up the leg. So after we had seen the venous duplex scan, we could see that this superficial venous incompetence, which basically means that she was identified on the scan. Within your veins, you've got valves, and those valves are there to close off to prevent the backflow of blood down the vessel. In this lady, that valve wasn't working. So when you looked at it on the duplex scan, you could see the valve flapping around like this. So it was no good to man nor beast, and that needed sorting out. So when we do this endovenous ablation, we brought her in. It's done under local anaesthetic, and you're awake throughout, obviously. Lots of patients find that a little bit distressing, but she was very good and tolerated it very well. Along the vein, we inject lots of local anaesthetic to numb the area so they don't feel the actual burning taking place. And then the vein then is burned in either 3 centimetre or 7 centimetre segments, and then that's taken all the way down then to seal off that vein. Over time then, that vein starts to destroy itself from the inside, but there are other veins obviously on the superficial system that are able to take over the role of getting that blood back into the deep system and back out into the body. This lady had a toe pressure of 0.7. Because of the site of her ulceration, we weren't able to do an ABPI. After we had treated both incompetencies in the arterial and the venous system, we popped her into a K2 compression bandage system. And within 4 months, we saw such a dramatic change in her ulceration that we were able to move her down into class 2 compression hosiery garments. She has bounced back into the system because when you treat venous complications, if you can imagine, it's like a tree. So there are lots of different branches that come off, and sometimes it's not always possible to treat every single vein, and you do sometimes get a recurrence or another vein will pop up somewhere else. We had a long chat with this lady, and the other option that we could have offered her was to inject it with some foam, but she wasn't keen on any more treatment, and she was quite happy to continue with compression. So she remains in her class 2 hosiery garment, and she's doing very well. We have had shared care with the community nurses, And I'm pleased to say that she's great. She's bombing around, doing her shopping, and she's fabulous. And I think that just goes to show how important it is to look at which system is causing the problem and addressing that. I've got one more case study. This is one of my favourite patients, and I think that if he could come and present to you himself, he absolutely would, because he'd love to tell you all about his leg. And this is a 57-year-old chap, and he was referred in by his GP for venous issues. So there were varicose veins, his leg was very swollen. Scan showed that he had both a deep and a superficial vein incompetence. But once they scanned him, they also noticed that he had an incidental finding of a popliteal aneurysm. Now, we get a bit twitched about that because obviously aneurysms, if they pop, they can be catastrophic. So that needed to be addressed toot sweet. So we brought him in. He had surgery and had aneurysm repair, which unfortunately, because of the swelling within his leg, and you can see on the top picture there, his wound to the back of his leg just broke down, and we really struggled to get anywhere with this for a while. So we brought him back in, and we managed to treat his venous problems. And I'm pleased to say that he's done very well. He's a very good patient. He's very engaged. He always attends his appointments, and he's been really good with redressing and applying his hosiery afterwards. He had been a bit naughty though, because he enjoys going out, enjoys the football, and did go out, unfortunately, a few times without wearing his compression garment and ended up returning with a new wound. We did scan him, and it showed that his graft that he'd had put into his popliteal area had got a little bit of an occlusion at the bottom end of it, but we angioplastied it, and we were able to try and open that back up. It's not as wide as we would like it, but it's probably the best that we're going to get it as. So because he still has this gross swelling of his lower leg, we popped him into a double layer of Actico short stretch, and that worked a treat for him. And you can see the progression through the pictures there of how much of an impact that had on his healing progression. And he's back in his full length compression hosiery garment now, and he's been brilliant. He applies his emollient every day, pops his stocking on, but he's an absolute dream. He's a lovely chap. So healing is possible, and it's just being mindful of which disease process is causing what, and having that consistency of care as well around it. So takeaways from today, just thinking ulceration of mixed etiology is not uncommon. It is out there, but I want you to be bold in your treatment choices and just think about, can I compress these patients? And if you're concerned or you have any worries about it, just ask, escalate it. And I think one of the key things is that I'm very lucky because I've got lots of access to things, and it's very easy for me to diagnose these patients. But having that collaboration and that MDT working is absolutely essential in managing these mixed arterial venous ulcers. There's lots of guidelines out there to help you. Don't be afraid to look. And that's the end of my talk. Thank you very much.
Thanks, Annie. That was absolutely brilliant. Lots of comments in the chat. We've got about 10 minutes now for Q&A. I think just to really start off by that comment you just made there about, networking, MDT support, because it's not always, it's a bit inequitable. And certainly the conversations I've had with community nurses, practice nurses, is the lack of access to vascular, or it takes a long time, so therefore decisions are delayed, but also there can be a disconnect between the acute and the community. So people need confidence to, when you're sort of seeing it slightly, out of the norm, because people think about strong compression, particularly only in specific ABPI categories. If we're wanting people to be more confident, people need to be supported. So that collaboration is really important, but it's not always consistent, is it, across the UK?
It's not, unfortunately, and I've certainly experienced that as a tissue viability nurse, and I I went and I knocked on doors and I asked, help me, because we've got a real problem and I need support and we need to work together, because otherwise this is just going to turn into a tsunami and these people are just going to keep coming back and coming back and we're not achieving anything. So that's what I did. I went and I knocked on doors and I asked, work with me.
Yeah, absolutely, really good advice. And I think, though, it's also, if people have been referred to vascular and there's going to be a delay because it's not deemed as urgent, it's having the confidence even to introduce that, as you said, that modified compression. There's been a couple of comments about asking you to explain what you mean by modified compression. Could you just elaborate again, just to make sure people are clear?
So years ago, we used to call modified compression, and I used to see it a lot when we worked with Professor Harding, Keith Harding. We would put 3-layer graduated tuber grip on people. Now we know that doesn't necessarily do a lot. It's not strong enough, and it just basically is tickling the leg. And I can hear Leanne Atkin talking in my ear that when we talk about, there are better systems out there now for achieving that modified compression. And I'm talking about systems like the K2 reduced system is a modified. Robinson's is another bandage company that have a 4-layer component, and some patients tolerate that better, but they also offer their own reduced system as well. And the other thing that we used to do years ago was that we would use a layer of wadding, then we would apply 1 layer of crepe bandage, and then we would put Coban over the top, and that would be our way of modifying compression. So just reducing that level down, you can go down to a 20 millimole system is a reduced system of compression. But
Thank you.
I know it's
Yes,
easy said than
I
done.
think sometimes it's good to maybe use tried and tested systems, I suppose, like the K2 reduce. I know Coban do a Coban light,
Yeah.
Coban 2 light. So at least you know what you're delivering. Sometimes people are unclear when you're adding different layers what actually you're achieving, and that creates some nervousness about maybe over compressing. But it's about working with your vascular, your TVNs, isn't it? Just to make sure that you're doing the right thing in terms of the right pressures. Right, let me just have a look at the questions. There's a comment here from Amy about having a couple of about elderly patients who are over the age of 85, that the GP is always hesitant in referring to vascular because of their age. What would your advice be? Is that ageism, or is it greater risk?
It is ageism, but
Yeah.
look at your patients, and if they've got a real good quality of life, why, and if this is affecting them, why shouldn't they be referred? I mean, if you're talking about somebody that is unfortunately bedbound and it's going to be difficult for them to get to an appointment and necessarily their quality of life is not as good as it should be, then maybe there may be questions that might have to be asked about what we can offer as a vascular team there. But certainly I think that's wrong. That needs to be challenged. But in the area that I work in, I've worked with tissue viability and podiatry, and we are very passionate about making sure that everybody gets a chance to be seen. And we set up a lower limb service so that anybody can refer into that service and you will get triaged and offered an appointment to be seen. Now, whether that is by podiatry, tissue viability, or vascular, you will get that opportunity to be seen, or we'll make contact with you and have that discussion about how we manage that patient going forward. But that's because we could see that there was an inequity then in care.
And it, it keeps people more mobile when their limbs are filled with fluid and they need to be assessed and have adequate compression. We know that by reducing that edema, we keep people more mobile and safer, don't we? So, yeah, I agree. I think, just because of age, it doesn't mean that we shouldn't refer people. There's a question here around peripheral arterial disease, and I mean, I think you've actually covered this, but whether you want to sort of clarify. So around how you assess somebody with suspected peripheral arterial disease, and the question goes on to really just get some clarification around compression, because guidance say 1 to 1.4 is considered for compression, but of course that would be strong compression. Can you clarify if 0.8 is safe for compression? I think you've already covered that in a really big way, but I think, is there anything else you want to say around that?
Generally, with a vascular patient, if you can palpate a pulse, then they've got good flow. So if you do your ABPI then, and it comes out as 0.8, then yes, get them in compression.
Yeah. Someone's asked you to explain what TBPI is.
Oh, it's a lot to go into for now, but it basically is where we take the blood pressure of the toe. So it's thought that by taking the blood pressure of the toe, the tiny, smaller capillaries at that level and the arteries don't necessarily calcify. There are some patients that again throws a curveball and you can clearly see calcification on x-ray, but it gives us another guide then of what the perfusion is like down to that lower part of the limb. So it helps to guide us about whether or not we would still feel confident putting compression on that patient.
I think TBPI, I think there's more conversations about this now because of the problems with maybe getting ABPI because of pain often, or limb size, isn't it? I know there's always conversations in lymphedema management that if they really do want to establish, arterial flow, they would use maybe TBPI. It's not routinely used across generalist sites. I think it's being introduced more, but it's not really out there, is it?
No, it's not. You may see it in lymphedema. Definitely you'll see it within podiatry, and you'll definitely see it within vascular as well. But it's not something that I would base my entire assessment on. For me, a good clinical assessment is what I want, and I'll be taking note of the patient's past medical history and any other involvement with any other teams that might in fact help with my diagnosis then.
I think following a really good, robust lower limb assessment and history taking, the ABPI or TBPI it shouldn't give you any surprises. I think already
No,
you have a really good idea of what you're dealing with. It's like the icing on the cake, isn't it? If
it
we
is.
can do it.
Yeah,
Yeah,
yeah.
yeah. Jonathan's asked about small ischemic ulcers on lateral malleolus that are more due to pressure when they're lying on that side at night. Would you still advise a venous assessment with a view to compression therapy? I suppose we need to be offloading, making sure that that's the case.
It sounds as though pressure is the biggest issue here, isn't it? And if removing the pressure doesn't help, then that would certainly be something that you could consider. But it would depend on, is that ulcer just purely that something's come because of being in bed at night, or are they in bed for longer? And then what is the underlying issues there really?
There's a comment here which, I feel your pain, Janet, around not all vascular teams offering end of venous ablation. I mean, it's a recommendation by the National Wound Care Strategy Programme, but I agree, depending where you are in the UK, as to whether they do it, it's a commissioning issue sometimes, but it has such amazing results. What's being done about that to try and make it more equitable, do you know?
It is absolutely post-coagulatory, particularly in England. I can speak for Wales that we're still strictly very governed by funding issues, and there is a strict criteria of whether or not those patients fit that criteria as well. And we measure by what we call the CAP scale. And you can search for that online and it'll give you an idea about the different progressions of venous disease. But certainly from an SVN perspective, we are constantly fighting from the Society of Vascular Nurses to try and raise the profile. And we attend the parliamentary group as well and fight the corner about how inequitable this is for patients if you can't access treatment when this is something that has been recommended by guidelines and shown and proven to be beneficial. And in the long term, this is going to save money for the NHS. But again, it's a commissioning issue, and that's really, really frustrating. And I feel your pain as well.